for joining the National Headache Foundation's Psychiatric Comorbidity webinar. Today we're joined by Dr. Maurice Preter. He's a psychiatrist, neurologist, and medical legal expert in the private practice in Manhattan. Dr. Preter, thank you for joining us.
My pleasure to be back here after quite some time. I've shown these slides, as it turns out, quite a while ago. It was back in November of 2012. Time does fly. And they're still good, so I'm just going to flip through them probably a little faster than, I don't know how many of you guys have been to this webinar before. There may have been other speakers addressing some of the aspects of psychiatric comorbidities in a different way, but I'm assuming you're somewhat familiar with some of the stuff that I would like to you to know about. And there's, the point is not to memorize any of this, but to do your own research and ask questions first of me and then of your doctor. The usual disclaimer, of course, applies. This is just informational, and it's not like, you have to talk to your own doctor about doing anything. And here we go. So we're all here to learn more about headaches. We know that already. I'm going to shorten this a little bit to keep it a little less academic. Let me see. Okay, the point here is this goes back, 80 years or whatever it is, 70 years. And at that time, neurology and psychiatry were still one field, believe it or not. Although at that time, the first rumblings of some sort of breakup were already there. People want to keep things simple, and I don't think it serves all headache patients all that well. Otherwise, we wouldn't be doing this tonight. Stanley Cobb, who was a titanic neuropsychiatrist, wrote about this thing. So, just keep the reference if you're interested, and we can have a discussion about this separately. There's a lot of information on my own website. Let me show you my own website. And before we started, I searched terms that are of interest tonight, which is headache. You can also search migraines and various other things, and it's a nice collection of, I think, interesting material that that shows you, a little more about how Dr. Preter is thinking, in case you're interested. But it's really relevant to intractable neuropsychiatric or neuropsychiatric conditions in general. There are hundreds and hundreds of articles that I curated a little bit, but mostly just posted them. So anytime, send me an email if you have more questions. Okay, going back to the slides, if I can. There must be here. All right. I'm going to skip through this. This was just published in 2012. So there's a nice little chapter on, believe it or not, alternative approaches to headache. I'm not an alternative doctor at all. I'm a scientist, and I teach at Columbia, I teach at Mount Sinai and various other places in the world, and I'm very much a scientist. So I was initially reluctant to go into what's called alternative medicine, but I'm definitely using some of that now with great success, while still being a psychodynamically oriented psychotherapist, and that almost approaches the status of alternative medicine these days, alternative psychiatry, because it's not really done all that much anymore for various reasons that we can discuss. I'm going to skip through some of this. We know that there's an overlap between physical pain, primarily we're concerned with is headaches, migraine, various other types of headache, and psychological suffering. What that is it's called multi-determined. Migraines are multi-determined. Chronic pain is multi-determined, means there's more than one reason for it. Just like there's more than one reason to have a rash, for instance, right? So we're talking about many things, and some of this does not apply to some people who have intractable migraines, because they have other reasons to have intractable migraines, and they better find out. But all in all, when we talk about neuropsychiatry, chronic conditions in neuropsychiatry, it's usually something that some doctors call functional, where you, thank God, you don't have a finding on your MRI or your CAT scan. You don't have an abnormal blood test. You don't have an abnormal neurologic exam. Because the last thing you want in neurology is have a physical reason to suffer, actually, because they're usually not good at all to have. So, but then of course you're left with now what? And neuropsychiatrists, including myself, deal a lot with people who come and say, now what? Okay, it's all very interesting, and think, my MRI is normal, and okay, what are you going to do with it? I still can't go to work. There are absolutely harrowing stories of people that are on the Twitter account of the Headache Foundation that really show the amount of suffering and family crisis, chronic pain and chronic migraine can cause. And there's a lot of that here, and it's really just really saddening. So, well, okay, now what are we going to do about it? First of all, my approach is, before we know what we're going to do about it, and some of you may take issue with that because I really think you have to drill down into the details of the situation, including understand the person really well, before you can even think about what to do about it. And it takes time. It takes a real relationship with your doctor. And it's not something that's so easily done these days because nobody has any time. But it's really the way to go. Okay, now we know already people have migraines, they're also depressed, all right? Some people have bipolar depression or manic depression, and the highest, what statisticians call the odds ratio, which is the relative risk in this paper by Lipchick and Penzine, is actually panic disorder, which is one variant of anxiety, and the others are kind of down there a little bit. Phobia, okay, but panic disorder is quite a bit more common, and as I am an expert in panic disorder, I guess, we'll talk about panic disorder a little bit more, and I'll show you some data that may make sense to some of you, as I hope. Okay, we know what depression feels like. Those who've had it know it, and there are quite a number of studies that show that there is what we already know. There's an association between migraine and depression. This is the DSM-4 diagnosis menu for panic disorder. And the one thing that I want you to notice here is that you don't have to be anxious to have panic disorder, not even in the DSM. You can just be absolutely miserable physically. So you can have a panic attack, but you don't have to have anxiety with it. You can have then anxiety about having another panic attack, which is understandable because it's not fun to have one. But you don't initially necessarily are an anxious individual, or you don't feel anxious anyway. Some more severe panic attacks can cause derealization. You really feel like you're not quite there. You're sort of detached and unreal, and in the extreme, you sort of have these events where you feel like you're floating above yourself, looking down on the scene that is unfolding on the ground, and all that together, there's quite a variety of, including abdominal distress. So it's basically the entire textbook of internal medicine and psychiatry. Not surprisingly, people with panic disorder spend a lot of time getting tests, because that's what we do, getting a lot of tests for various reasons. And of course, they are ideally negative. And then the question still is, what now? Again, I like to go back to the old masters. This one is from 1895. Sigmund Freud was the first one to describe the panic attack, and it's still the best description. And most of it has been integrated into these various DSM versions. Okay, this is more specific to headache and panic. This is one of the classic studies published in Neurology quite some time ago that proves what we already know, that there is a bidirectional, meaning it goes both ways. You can have first anxiety and panic and then develop migraines, or first migraines and then develop anxiety. And it's quite an overlap. Here we are. Of note here would be that it's not just the classic migraine without aura. It's all types of headaches that have this overlap with panic disorder. Now, this is more and more coming to the fore. I think there was just a week ago or so a new paper that clearly shows the massive antecedents of psychological traumatization in people with intractable headaches. And that started really with Dr. Breslow's work way back in, so to speak, way back in that paper, dated 1999, and it's clearly coming to the fore, and more people are becoming aware of it, which is a very good development. Okay, what we can see here is that the more you've been beaten up, the more potentially you're at risk of having this is about trauma and PTSD, so let's skip that. There's a lot of interest in the Veterans Administration because it's really a big problem for returning soldiers. I'm going to skip all this, but I want you to just be aware that people have tried, to the extent this can be studied, have tried to study the antecedents, which is what sort of things happen to people before they have their first panic attack. And this, while that's a little bit hard to study, in the real world, there is some data that show that people who have sudden panic attacks have, in the last year or so, had some sort of major trouble, usually a loss or a death, or some extremely difficult situation in their lives, including loss of job, loss of language, loss of country, having a stroke, losses in a very general sense. We already covered that, and there's a little bit of literature on major life changes before and after the onset of chronic daily headaches. So it looks like suddenly panic and various types of headaches. And I sort of intentionally don't separate the various headaches because for our purposes, they are kind of the same, which may offend some of the headache experts that feel like chronic migraines have nothing to do with chronic daily headaches. And but in terms of comorbidity, psychiatric or psychological comorbidity, they look very similar. Okay, this is from that paper. Again, this is not studied very often because it's hard to anticipate those things, so it's all retrospective. But it looks very similar once you draw a line through this thing, similar to that earlier paper that shows that people with panic disorder have their first panic after some really disastrous event in their lives, and it looks like it's not that dissimilar from chronic daily headache patients. And not quite surprisingly, the older they are, the more at risk they have been to accumulate, hard knocks in their lives, and the more they suffer from chronic daily headaches. Okay, we have established that already. It's still very much a problem. People are working on it, but much more needs to be done. Okay, we'll skip that one. Sorry for the design of this thing. This is clearly 2012 or worse. But this is one of the most interesting papers I've ever read, because it really shows that extremely well designed. It really shows that if we focus too much on like one region and one headache type versus another headache type, we're missing the forest while looking at a few trees. And I think we need to look at the forest and see what we can do about the whole situation as both patients and doctors, and work on this together. Okay, I'm going to skip Floyd. This may be a surprise to some of you, although not all of you, because there's really a lot of overlap between these various types of pain. So a lot of people have not just migraines. What makes it even worse, they may have other types of pain. They may, have back pain, and they have these, lower body symptoms sometimes that are very disabling in many ways. And where do you go? Well, you go to various doctors, and the doctors aren't necessarily talking to each other, and so that also makes a lot of chronic pain, including chronic headache patients, very angry, which is also something that shouldn't be that way and doesn't have to be that way. Okay, so we know there's a urology side to these so-called unexplained or medically unexplained symptoms. That's another interesting paper that shows that some of this, of course, starts very early in life, which is not really a surprise. And, that's certainly something, perhaps even a topic for a separate webinar, and people will be able to comment on this once we open the mic. All right, so what's the take home? So you sort of get the idea. I'm going to skip through this real quick. It's a little bit too complicated. This points to our own research done at Columbia a few years back. That's the hard data. It's a little hard to read. It's very technical, but there are some other papers posted on my website that
Dr. Preter, excuse me.
show that.
Dr. Preter,
yes.
You zoom in on your slides. They're at like 50%. Can you make
so
them a little
sorry.
bit bigger?
Oh my God, this is horrible. Sorry. I hope that's okay. Is this better? Is this any better?
Yes.
Okay, sorry for that. So, I'm not asking you to read this thing. I have a hard time understanding some of this by now. But there are easier to read papers that are all posted someplace on my website and other people's websites, and they make sense. And see if they make sense to you. I'm going to skip through this. This is just another perspective on this argument. It shows that a lot of people really leave, standard medicine and look for help elsewhere, hopefully for the better. So there's a great need for adapted medical services for people with migraines. Again, this is sort of the Asian version of the forest and the tree. You know, some people look here. Let me see if you can, hope you can see this. Some people look at this stuff, some people look here, and it's really all one big white elephant. And people get sometimes, you know, not the most optimal help because they only get help here and not here and not here and not here. Needless to say, if you have chronic pain of any sort, you don't sleep well at night, which causes another set of really difficult conditions and adds to the duress. Okay, we've done that already. This is my pitch for, you know, more humane and also rather cost-effective healthcare. Hard to do this in reality, but that doesn't mean it doesn't apply anymore. Now, this is from a visit to China as a consultant there at various hospitals, and this is a consultation in one of the best hospitals in Shanghai. It shows you, you know, how many people are waiting for a 1 to 3 minute encounter with a doctor. Now, in 1 to 3 minutes, you can do pretty much nothing except prescribe either tests or pills, but you cannot possibly know what this person is looking for and what they need because it's simply impossible. And the result of that is that there's actually a lot of rage and anger against doctors, and almost every week when you look at the news, there's someone who kills or at least injures a doctor somewhere in China. And of course, the system here is a little more civilized, but doesn't really solve the underlying alienation. Now, drug therapy is relevant. I'm not knocking it at all, and I use it all the time, but you have to be careful. People with chronic pain have different sensitivities, and they may become dependent, have, you know, more adverse reactions perhaps sometimes, and it's certainly a part of the approach, but it cannot be the only approach. And there are issues of informed consent because there is such a thing as psychotherapy. Again, it's a little bit out of favor because it's so involved and, you know, costs a lot of time and money sometimes, although it doesn't have to. But it's clearly not really a focus of current, you know, medical or neurological research certainly. And then, of course, since a lot of this is based on, you know, massive traumatization of various types, including sexual, you know, losses of early losses of parents, divorce, big time life events, which in and by themselves are not a disease. So they, you know, they should be prevented rather than treated to the extent they can be treated. Okay, that was quick. I think we should probably take a few questions, and if people are ready. How are you guys doing out there? I hope you're not asleep.
No, they're actually very attentive. It
Can't
looks
hear
like
anything.
our first question.
Yes? Who is not attentive? Can you please wake that person up?
I wish we could. So this is a question from Veronica.
Yes. Okay.
And she'd like to know, how long do you wait before getting treatment for an intractable migraine?
Well, how long do you want to wait? And do you really want to walk around with an intractable migraine? No, you don't. So I guess, you know, it's you don't have to suffer through this. And what's the point of suffering? So if you feel like it's intractable, which requires technically that you have sought treatment before and it didn't work, and then another treatment, then another treatment. But definitely you don't, you know, for many reasons, you don't want to walk around and suffer from something that can be so disabling that you risk your job, your relationships, so no, it should you should not wait. That's only my perspective, but I don't think you should.
It says my headaches are clearly linked to anxiety triggered by stress and overwork, yet no one knows what to do about them. What preventative prescriptions would commonly be prescribed for anxiety-related migraines?
Okay, so it's a very important question because you know, how do you consider stress and overwork a disease, or is it something that needs, you know, if possible, other types of interventions, such as what sort of stress are we talking about? Is it relationship stress? Is it lack of sleep because you have, you know, you're an attorney, or, you know, you're young professional, or working 18, 20 whatever hours, you know, most days? Should that be medicated, actually? And a lot of people feel like, yes, absolutely, because they want to make a career, and if they don't medicate it, they will function less well, and so it's a risk-benefit. Now, in terms of treatment of panic disorder, which is, you know, treatable with pills, and I'm not saying it shouldn't be treated. There's almost nothing worse than intractable conditions of any sort. Certainly, migraine and panic disorder are up there with, you know, serious medical illness in terms of the kind of stress they cause, without, fortunately, you know, hurting anyone sort of, you know, physiologically or you know, biologically. You know, they don't kill like a chest pain, panic, a cardiac condition with frequent chest pains. Those things kill. Anxiety, as bad as it is, and migraine, as bad as it is, doesn't usually kill. So that's good to know, which also means you have some time to figure out what to do about it in a safe way. And as much of an emergency it is functionally, it's not a medical emergency usually. Again, you know, you have to check with your own doctor. Cannot decide based on what we're doing here tonight what a medical emergency is. And that's not the point here. But you know, usually what do psychiatrists do when they see anxiety, whether it's migraine related or job related or God knows what related? They, you know, unless they are primarily psychotherapists, they do prescribe, and I certainly prescribe as well to some extent, usually very low doses of, you know, so-called anti-anxiety medications. One of the better ones in that area is, of course, you know, the benzodiazepine's, and they're widely used for anxiety. Clonazepam is certainly one of the most commonly used medications probably in the world since, I don't know, the 1960s. It's the more powerful version of Valium. Valium has been around since the late 50s, I believe. So, but, well, you know, I'm not clear why nobody knows what to do about them. Because either they're clearly, you know, if it's really just about prescriptions, it's not difficult to find something that lowers your anxiety, but it may also, you know, make you tired. Maybe that's what you're referring to. I don't know how we can have a discussion about this, because I just see like a 5-liner from you, and I would like to hear more about why nobody thinks this can or knows how to you know, treat this situation. My guess is that it may be related to side effects, but I can't tell that without you know, giving me more information.
So our next question looks like Emma. She wants to know, how can you function at work when you're taking so many medications? Looks like she's on Phenergan, Imitrex, and Baclofen.
Baclofen?
Baclofen? Okay, Baclofen.
I don't know. Sounds like
word. Sorry. Yes, Baclofen.
Well, have you, you know, asked yourself, do you need all that stuff? Have you discussed it with your doctor? You know, most medications, especially these very, you know, long lists of, you know, complicated to use sometimes, like Baclofen is under certain circumstances a very good drug, but when they show up in sort of, you know, off-label type of situations, or at very high dose, we'd usually wonder, are they necessary? Why were they introduced? And usually they're introduced because, the other stuff hasn't worked. So I would take that back and, ask your doctor, why is this really necessary? Can this be reduced? Are there other ways of treating this? Are there realistic ways of treating this in the time available? A lot of insurances think they really need to save money, and then, how many doctors can you see for how long? And, can you pay for your own psychotherapy, that kind of stuff. And so there are lots of, questions that are, buried in your question, but it sounds like you feel like you can't really think straight, maybe, and that definitely shouldn't, just like the first question, how long you should wait from Veronica, I don't think you should wait at all, because you don't want to continue to be feeling this way. If possible, if there are other ways of dealing with your migraines.
All right. See our next question. What is your opinion on the use of an occipital nerve stimulator to treat chronic migraine in someone with comorbid anxiety, panic attacks, and depression?
Okay, well, that's a good one. Okay, I commented on this in that chapter that I showed you earlier. Where is it? Chapter, this one. Hold on. That really nice book by some of my very esteemed colleagues, and with a really nice cover that doesn't show up for some reason. Here it is. Okay, I did comment on this in our chapter. I think it's a little, let's say, invasive for my taste, but again, a lot of doctors feel differently about it. I would use anything that is that invasive as the absolute last resort, especially since it's not 100% effective, and so I would do everything that is non-invasive first, and that may well include acupuncture, that may well include Botox, which is very safe in the right hands. So all those things, I'm not afraid of needles at all, but anything that involves implants and tunneling the skin and putting stuff and leaving it there should really be reserved for the last resort, and also only if the patient understands that there's a risk a little bit and it may not work, and why go through these kinds of high-tech procedures when there are easier ones first. So I would do that. I'm not knocking it. I think it has a place, but it's down the line. In my book anyway. Again, that's just my book. I think I made a little bit the point. I encourage you, if you're interested in any of this stuff, look around the web, not just for my stuff, but also for some of the, associated or overlapping conditions that I did mention, like other types of pain, back pain. Back pain, if you have it, is a nightmare. It causes untold problems and costs untold billions, and all that stuff, should that be studied together, separately? And again, I'm addressing functional pain, not a slip disc or something that needs surgery, and I'm addressing functional headaches, not secondary headaches, which absolutely need to be addressed in a very different way. But there's a whole world out there of people suffering and getting little help from of chronic pain in the current system where everyone is in one specialty and a quarter of a specialty. And I don't think that serves most neuropsychiatric patients that well. But again, this is my Dr. Preter soapbox talk, and a lot of people may find that irrelevant and disagree wholeheartedly, and that's fine too.
Unless someone is still typing,
Hello?
raise your hand and let me know if you're still typing. Other than that, no other questions have come in. And
Okay. I hope this was useful. I much enjoyed it. Next time we'll have a call-in kind of thing if you like. And I wish everyone the best, and any questions, talk to NHF. It's a terrific Twitter account, terrific website, very, very helpful. And use it. And ask questions to yourself, of your doctor. And that's how it works. Okay, thank you so much.
Absolutely. Thank you so much for addressing the questions that came through.
My pleasure, very much. Okay, all the best. Bye-bye.